Hi everybody, this is Jon Roffman. I'm a managing principal with ZS Associates. I'm joined here today by Dr. Doug Blanyey. Dr. Blanyey is a professor of medicine at Stanford University, also a member of the ASCO Value Task Force and a longtime volunteer for ASCO. And we're here at ASCO 2016 to talk a little bit about value frameworks. So one of the things we wanted to understand a little bit more about is how are you seeing these frameworks actually play out in clinical practice? What kind of an impact are they having?
So the first thing we did in the Value Task Force, this was put together 6 or 8 years ago now, was actually articulate that it's okay for doctors to talk to patients about the cost of care and about what this care is about to cost them, because the maelstrom that patients are thrust into, gee whiz, I've got cancer, big C word, and then it's okay to talk about the cost of what's going to happen to them. Now, it may not be my role as a physician to say, well, this is how much it's going to cost in the next month, this is how much this treatment costs, but at least our task force gave permission to oncologists to say, okay, I have someone in my office or I have someone here at the cancer center that can help you talk about or help you understand at least what the cost of these are about to be. As this process evolved, as you point out, NCCN, ASCO, and others developed this framework to say, okay, this is what it's going to cost. How much value is this going to give to the patient? So it's an evolutionary process. Physicians aren't picked to talk about what it's going to cost. We are not trained to talk about what things are going to cost, and it's really not our inclination to talk to somebody with a serious illness about what it's going to cost. So we gave permission for doctors at least to talk about to their patients what the costs are going to be coming forward.
Great. And with all of these different frameworks that we've talked about, ASCO, NCCN, ICER, et cetera, how do we reconcile the fact that there are so many different definitions of value? How do we, will we eventually get to sort of one definition of value, or how will that play out over time?
Well, I think value means different things to different people. It certainly means different things to a payer than it might mean to a cancer patient, that it might mean to the cancer patient's loved one, for instance. You and I might think a value of a dinner tonight would be very different. We might also have very different opinions on the car we drive. The thing that's missing from all of these frameworks is the patient perspective, the actual customer, who's going to actually undergo this. And the next iteration, and hopefully the coalescence, will involve patients and patient-reported outcomes and what is valuable to patients. So I think that's where we're going to need to go next. And we need to listen to our patients both en masse and as individuals.
When we talk about value and manufacturers and their role, the conversation typically shifts towards price. Are there other things, though, that manufacturers can be doing beyond price to demonstrate the value of their products in a more effective way for patients?
Well, yes. The traditional endpoint of studies have been either disease-free survival or overall survival. We're seeing a move to incorporate patient-reported outcomes so that we can say to patients, well, this drug may be a little bit more expensive, but there's less mouth sores, or this drug may be a little cheaper, but there's more neuropathy with them. So I think the incorporation of patient-reported outcomes so that I can have an intelligent conversation with my patient about the merits of the therapies that we have to choose from in certain situations.
Do you see in the future these value frameworks being used more heavily in everyday clinical decision making, and if so, what would it take to get there?
Well, I think part of the thing that I see emerging is drug treatment pathways, and that more patients are going to be treated according to pathways that have been decided upon in advance, so that I don't have to craft a chemotherapy regimen for every patient as they come along. I can talk about a pathway. We have this 3 treatment regimens. And oh, by the way, this one has these side effects, and the cost or the copay for these various options are well known. So I think as we go forward, pathways are going to play a larger role, and that'll give me more time to pass off to my team stuff that is done a little more routinely, but have more of my personal time to invest in that bedside to chair to bedside or across the table conversation with my patient.
Thank you so much for your time.
Oh, okay, this is great, John. Thank you.
It was great to talk to you. Thanks again, everyone. Hope you enjoyed, and we'll look forward to seeing you again next time.